If cancer has spread beyond a localized area or is just prone to spreading to other areas, the recommendation is that you give systemic therapy, such as chemotherapy. Treatment of cancer with chemical agents is usually based off of genetics, the cell cycle, testing positive for specific growth factors, and the tumor burden. We have a term that is known as adjuvant therapy. This is when we use multiple modalities within a certain time period to control or cure the cancer. Unfortunately, most cytotoxic agents are not cancer cell specific. What I mean by that is all cells are usually affected by the chemotherapy, particularly the rapidly dividing cells. And those cells include skin, hair, nails, intestinal tissues, spermatocytes, and blood-forming cells. That's what I have on the right lower hand picture there, a boy who is anemic. Now your book actually talks a lot about a lot of different medications that we can give to our patients. However, have no fear, I am going to light the way for you. Let's begin with the first one called cyclophosphamide, also known as Cytoxan. What's important to know about cyclophosphamide is that we must always administer it with this drug called Mesna. Mesna is a cytoprotectant medication, and it's going to coat the bladder, so whenever we administer our medication, it's not going to have this dangerous metabolite irritate and ulcerate the bladder. So it sort of is like the Pepto-Bismol for the stomach. It's the Pepto-Bismol for the bladder. And to that note, as I'm administering this to the patient, I'm going to inform them to let me know if their urine turns pink. If that's the case, we may need to withhold this drug for a little bit. Now, do know that cyclophosphamide is pretty famous for causing secondary malignancies, meaning I'm giving this to you now to treat your lung cancer. However, in about 20 years from now, you may also develop lymphoma or leukemia. The next medication we want to administer, or we want to know about, what to know about administering it, is 5-FU, also known as fluorouracil. The thing about fluorouracil is it can cause some pretty bad cases of stomatitis. We want to monitor that, and if it becomes so bad, this actually may be an early sign of toxicity and should be reported to the doctor. The next drug I want to discuss is called vincristine, also known as Oncovin. This is frequently given for our leukemias. However, what's important to know is that there is a really high risk of neurotoxicity. What happens in neurotoxicity? Patients will have they'll have orthostatic hypotension, they'll have constipation, they'll have peripheral neuropathy in their fingers and in their toes. They'll have impotence. A lot of things come with neurotoxicity. Oftentimes for a patient, we will have to be giving them medications to help stimulate the bowels. We will have to give them nerve pain drugs. Oftentimes, this may be a limitation of the drug because if the pain is so severe, the person is not allowed to take vincristine anymore. Doxorubicin, also known as adriamycin, or patients call it the Red Devil. One of the reasons they call it the Red Devil is because it actually is red. It's bright red. I'd probably like to refer to it as a hot pink, actually, if you ask my opinion. This medication is a severely cardiotoxic medication. So, in order to be eligible to take this, we need to have an echocardiogram done just before the medication, and usually intermittent and following the medication, like a few months afterward. This is going to be quite important for us to monitor for pulmonary edema, swelling in the ankles, crackles in the lungs, jugular venous distension, anything that would let us know that the heart is decompensating And if that's the case, we actually are probably going to have to come off this medication. Small little side note, this will actually cause harmless pink shades to their urine for about 48 hours. So in one situation, such as in doxorubicin, pink urine's fine. In another situation, such as in cyclophosphamide, pink urine is bad. I'm looking at hemorrhagic cystitis there. Our last medication I want to discuss is called Camtazar, or irinotecan. What's important to know about irinotecan is that it unfortunately causes diarrhea. Don't ask the question, are you having diarrhea? That one should be assumed. Your question is, how bad is your diarrhea, or how severe? Now, with all of these chemotherapy medications, please pay attention. When you are going to administer it, the nurse needs to know the nadir of each chemo. What is the nadir? Well, this means the time period where patients will have the lowest blood cell counts, particularly the white blood cell count. To say it in a different way, patients are very susceptible to infection during their nadirs, and they should be very conscious about infection control. We should be conscious about infection control. In fact, we as nurses are going to check the patient's lab work periodically, particularly during the nadir time period, and we may actually have to hold the next chemo dose if a patient hasn't recovered yet from their nadir. All drugs, by the way, have different nadir schedules. Just as an example, nadir of vincristine is about 7 to 10 days. The nadir of fluorouracil is about 9 to 14 days. This is important because we try to, the word is not scatter, we try to rearrange the administration of these medications so the nadir doesn't land at the same time period, because that could be bad. We could actually kill a patient if we try to do that. I know that might have been a lot to take in on the last slide, but all we need to do is just keep in constant communication with our patient, because there are some nasty side effects to those medications, and we need to find out what can your patient tolerate, because we want to make sure we're killing the cancer and not them. Because if we're doing both at the same time, we've completely defeated the purpose of our chemotherapy. So please, as you hear me talk about all of these major side effects and issues, and watch for this and watch for that, know that sometimes these do occur, but then they're going to occur to a degree that is so intolerable to the patient that they would rather die than take another dose of chemo. I feel like the movie Wit does a pretty good illustration of the consequences of, giving chemotherapy and the consequences, unfortunately, of not taking chemotherapy. Death. Such a hard battle, but let's keep going. We're going to talk about molecular targeted therapy. So, cancer cells have more active signal transduction pathways and transcription factors which lead to excessive division. Well, we are going to take advantage of these differences, and we're actually going to block it or flag it in this way that we are going to disrupt or activate the body's own immune system to take care of those cancer cells. Let's look at monoclonal antibodies. The drug that I'm going to declare as the prototype is rituximab, also known as Rituxan. This is great in that when we administer this, say for a person who has non-Hodgkin's lymphoma, then we are actually going to flag those crazy lymphoma cells, and the body is going to then now recognize and be stimulated to destroy the cancer cells. The big thing about this that we need to monitor for is life-threatening allergic reactions such as anaphylaxis. The next drug I want to talk about is Velcade or bortezomib. what's important to know about this one is there is a high chance of developing tumor lysis syndrome. This is also given to patients who have lymphoma, and if they have a high tumor burden and we give this medication, and high tumor burden means they have a lot of tumors, but if we give this medication, then we are going to all at once suppress cell division, and then we're going to enhance cancer cell apoptosis. And as that happens, all of these cells are going to be rupturing at one time, and it may be too much for the body, especially if they have that high tumor burden. We're going to get a little bit into tumor lysis syndrome later. The last drug I wanted to highlight is we're going to call it Toracel. This is a angiogenesis inhibitor, meaning it stops the growth of new blood vessels. That's great because a tumor is constantly creating new blood vessels for it to invade other organs and tissues. So if we stop that process, we stop the tumor. However, please do not have major surgery or a major procedure on this patient within 28 days of this medication being administered, because that now will be a risk for them to bleed out and they are never going to heal. Let me repeat that. They will not be able to heal because we have blocked that process for angiogenesis. See, we have healthy angiogenesis and we have the unhealthy angiogenesis. Unfortunately, this drug is not smart enough to know the difference between the two. So, if a person has a major surgery, make sure to discontinue it at least 2 months prior to. So, better safe than sorry. Last slide for meds. Okay, so we can slow down somebody's cancer growth by changing up the hormones that are usually feeding it. A lot of tumors are hormone sensitive, meaning they will grow rapid in the presence of that hormone. So if we can give the antidote, basically, we're going to decrease the hormone amount, and now the hormone sensitive tumors can't grow, or they're going to grow at a very slow rate. So for my prostate cancer patients, we can either give them estrogen or progestin or antiandrogen, and if this is the case, we are basically giving them female hormones, as you could probably guess. We're going to see feminizing effects such as gynecomastia, which is they're going to have excessive growth of breast tissue, especially around their areola and the nipple. We're going to see acne, hypercalcemia, liver dysfunction. All of those you could read for yourself. The 2 blanks I have there would be clots. Put them at risk for clots, and it's going to put them at risk for bone loss. Otherwise, we're going to induce osteoporosis. So patients on the listed above medications will oftentimes have to go on a biphosphonate, just like we would for a female who has osteoporosis. An example would be like Boniva or something. Okay, looking down here at androgens. Androgens are the male hormone, and if we have a breast cancer that is fed by estrogen, we can also, we can give androgen. Unfortunately, we're going to have a viralization of the voice, meaning they're going to get a deep, husky voice. We're going to have hair on the face, hair on the chest, and right, because that is always lovely. I'm sure the patients can appreciate that. We can give progestin. The thing about progestin is also noted that it's going to cause clots and fluid retention. Okay, now for our special patients who have the HER2 positive breast cancer, as I explained in, it's not Angelina Jolie, who's that other girl? Oh, I can't remember her name. The 90210 person. She probably had to take an anti-estrogen such as tamoxifen. And this can cause hot flashes, doesn't matter what age you are, you will have hot flashes, headaches, and nausea vomiting. And yes, this does increase our uterine cancer risk. However, it will not matter if you've had a hysterectomy. Doctors want to give the patient just the right amount of medication, which makes it poisonous to the cancer cells, but not enough to hurt the rest of the body. What a very hard balance to make. So what we want to do is incorporate the patient's height and weight into our dosing. And what we're going to do is the doctor is going to give us, say, the order of doxorubicin 50 milligrams per meter square. What we need to do as nurses is we need to calculate, well, what is their meter square? What is their BSA, their body surface area? I have a little formula right here, and it's pretty simple. It is their height in centimeters times their weight in kigs divided by 3,600, and then you're going to hit that little square root button. Just as a point of reference, your average male and your average female numbers are right there. Male is 1.9, female is 1.6. But of course, the taller they are or the heavier they are in weight, that number is going to change and go up. So let's figure out how to calculate this. I have a little example here. Ravina is about 110 pounds. She's 5'8" Please convert that into the metric system. And do remember that 2.2 kilograms is 1 pound and 2.54 centimeters is 1 inch. I'm not going to wait. I'm just going to go ahead and keep clicking through. So you better pause it if you know better. Okay, did you come out with this? Right. So now we're going to multiply that 172.72 to the 50. And did we get, well, I'll give you a second. You divide that by 3,600. Did you come up with this? 2.39. Please do not stop here. You must continue on and hit that square root button. So go ahead and hit it. Did you get this? Right. 1.55. That is Mrs. Ravina's BSA. Now at this point, I'm going to take the 50 milligrams and multiply it times somebody's BSA, which in her case, 1.55. All right, so now let's look at the scheduling for chemotherapy. It is given on a regular basis over a period of weeks, and this is so we can maximize cell kill and allow the normal cells to recover. When it comes to administering chemotherapy, we really would like to give it into a central vessel. And because a patient has to be accessed again and again and again, oftentimes we have a metaport. Sometimes they also call this a portacath. That's going to be instilled into somebody's chest. And chemo is going to be administered via this Huber needle or this 90-degree needle. We can also administer medications intrathecally, meaning right into somebody's spinal column, intraventricular, so right inside somebody's ventricles in their head, or how about intraperitoneal? Where is that? Intraperitoneal. That would be in the lining of the abdomen. Topical, they also have intraarterial, goodness, into somebody's veins, intravesicular. Okay, so let's learn about the word extravasation. This is when medication is delivered into the subcutaneous tissue accidentally, and it places this patient at risk for necrosis. This is actually what a bad extravasation looks like, and it is a horrible complication of our medication administration. You want to ask, well, why didn't the nurses see this? Maybe he or she didn't know what to look for at the insertion site. What do you notice? Well, you're going to notice swelling. You're going to notice discoloration, possibly leaking at the site, tenderness, and pain. Metaports should not be painful. Patients shouldn't report burning or discomfort. We could possibly have done some education to the patient about frequent monitoring of this and reporting signs and symptoms, but the big thing is prevention. And how does a nurse prevent this? Well, it begins by connecting your little syringe to the hub and aspirating. We're going to aspirate and hopefully obtain blood. This is a good finding and indicates that our Huber needle is in the Metaport and that the Metaport is intact and it's working well. Now, if we are not able to aspirate blood, oftentimes we will try to reinsert a new Huber needle, and if that doesn't work, then we have to call the doctor and send the patient for a Metaport check. What this means is they're going to go down to interventional radiology. It's a unit where they're going to use dye, a radio opaque dye. They're going to shoot it through the Metaport, and they're going to watch it to see if it goes where it's supposed to or not go, like if it's malplaced or something. All right, my two other things to remember about safe chemo, looks like I already clicked it, is check the lines frequently for leaking and infiltration, and please do not touch the bags or the tubing without chemo gloves or double gloves in your gown. Administering chemotherapy should be about patient safety, but it also has to be about nurse safety too. Many nurses who want to work with cancer patients have to get chemotherapy certified, or we say chemo certified. This means they have completed additional training and they have advanced knowledge about the medications they are about to administer to the patient. Not only this, but they will also know what to do if something goes wrong and maybe the medication gets disconnected, anything like that. Most chemotherapy protocol includes the strict guidelines for handling chemotherapy drugs or excreta from patients. This protocol will have to be followed usually about 48 hours after receiving some chemo. Do you know that chemotherapy is a high alert drug? And what this means is it must be checked with another nurse, but not just any nurse. It must be a chemo certified nurse. Otherwise, you might not even have checked it with another nurse at all. They gotta know what they're looking at. Now, if chemo is leaking, we're going to treat it like a true biohazard spill, which requires special cleanup. Because let's face it, you are at risk for absorbing the chemo and experiencing the same side effects like the patient would. I do have a quick sad story about a student who accidentally disconnected the wrong tubing. This was at another university that I worked at, and the nurse had told that student to go and help the patient in XYZ room to the bathroom. He went into the right room, but that room was not the right room that the nurse intended. Just so happened that that patient, who the student should have been in there anyway, actually had to go to the bathroom. And so while he was in there, the patient said, "This line has me connected. I can't go to the bathroom," and the IV pole wasn't on wheels. Well, what did the student do? He said, "Well, let me call for help." But this patient said, "I really gotta go." He couldn't figure out how to turn the pump off. And so he ended up disconnecting this medication. He walked the patient to the bathroom. And right about that time, the nurse came in the room to discover that the student was assisting the wrong patient, and the medication that was disconnected and never stopped was chemotherapy, which was dripping all over the floor and all over the bed, and not to mention the student had touched it and it dripped on him. It was not a good day, and the patient had some of their chemo, very expensive chemo, had to get thrown away because of contamination. Please read the labels on the bag, and if you're wondering what happened to the student, it's probably not good that you wonder. Quit being curious. Okay, let's talk about medication disposal. So if we are taking medications PO, please make sure to discard it into the black waste bin. Like the packaging, I mean, please I can't find my words. Please discard it in the black bin. For other chemotherapy that has trace liquid in it, you can discard it in the yellow container. Okie dokie. I also get asked this question. I'm just going to give a quick answer. Can a non-chemo RN, non-chemo certified nurse, give PO chemo to a patient? The answer is, it depends. You actually have to check hospital policy, but chances are it might actually be okay. PO chemotherapy, but please don't think it's not any less potent. Don't get yourself in trouble. Check your hospital policy.